Good afternoon, ladies and gentlemen. That's what? Eh? Okay. So, welcome to this course. We'll start this at 3 o'clock. This is cataract surgery in zonulopathy. We just given it a fancy name, zonulopathy, but we'll be talking about subluxation. That's it, basically. And we have excellent faculty. We have Dr. Chitra Ramamurthy from I Foundation, Coimbatore, Dr. Sudeep Das from Shankara, Orissa, and Dr. Matthew Kurian from Chaitanya Hospital, Palarivattam. So, I would invite my faculty to please come forward to this. I wouldn't call it stage or whatever, but these seats in front, please. And we are supposed to start with Matthew Kurian, so he must be joining shortly. Matthew is entering from the door behind. Matthew, please come forward, please. Come. So we'll have a detailed discussion at the end of the session. But basically, I think we'll go ahead. Matthew's talk is on. So he'll talk on, we'll go in a systematic pattern. We'll go with the preoperative evaluation, the type of phaco procedure, and the stabilizing part of the phaco procedure, and then IOL implantation. And we'll come to the discussion at the end. Okay, over to Dr. Matthew.
Thank you to Team KSOS and Minu for this opportunity. So, zonal weakness, zonulopathy of various extents is pretty common in our surgical setting, and preoperative being prepared is very important. No financial disclosures related to this presentation. So it can be during cataract surgery, or subsequently it can also affect the intraocular lens, so we should be careful about that. The important thing to realize that it can be localized or diffuse, and it can be congenital or acquired. In the presence of a congenital situation, it can be like a coloboma, and there is a static small bag with a focal loss where a small amount of correction only is required. Acquired because of trauma, again there is a static, it is not a progressive lesion, and the rest of the bag is usually normal if the trauma is blunt injury. If it's a diffused one because of injury, example during a vitrectomy, there can be associated posterior capsular deficits as well, but diffuse with pathology, and that is the most important and critical criteria. Gradual progression will be associated with diseases like pseudoexfoliation, accelerated progression, example in homocystinuria. The etiology is multifactorial, marfans, homocysteine, usually a lot of syndromic things, so we should be looking at the general health of the person, not only for taking care at the time of anesthesia required in these people, but also to help to localize what is the possible type of syndrome that has caused this disease. And in adult onset, it is progressive. Pseudoexfoliation is the commonest in our situation, but retinitis pigmentosa is also pretty common. The clinical examination, and this is very important to identify family history. Many people would have forgotten the small childhood traumas, and this is important to elicit. Sometimes you may see scar on the cornea, you may see some local foreign bodies. People who are in the stone breaking business usually have blunt injuries. Visual symptoms may not be very typical of usual cataract. Systemic evaluation, like I mentioned earlier, is very important. Cardiac evaluation is compulsory for marfans. Ophthalmic evaluation, look again for phacodonesis, because subtle phacodonesis may be the only indication preoperatively that this is a person in trouble. Get the pupil as well dilated as possible. Ask the person to look extreme left or right while looking on the slit lamp from the other angle to see if the edge of the lens equator is visible. If it is round or flat, that gives different indication as to what you will encounter intraoperatively. Look for anterior and posterior capsular damage, and the density of the nucleus. If it's a hard cataract with this kind of a compromise, it becomes much more difficult to manage. Posterior synechia and presence of vitreous prolapse may sometimes be the only indications that there is a possible problem. Good glaucoma evaluation is necessary, especially in the presence of blunt injury. Look for iridodialysis, look for angle recession, cyclodialysis, a retinal evaluation to look for retinal dialysis or a choroidal rupture. And in cornea, assess the specular, because there will be a lot of intraoperative manipulation which is going to be critical if the cornea is already compromised. Most importantly, don't finish with a slit lamp examination. When in doubt, make these people lie down, because you may see a lens which is sitting there with some amount of tremulousness, but it goes to mid vitreous suddenly when you make the patient lie down, or that may be the place where you get the anterior chamber depth irregularity or asymmetry, which will indicate that you have a challenge there. So a round or scalloped edge like this indicates that there is zonules there, but it is weak or lax. Whereas if you find a flat surface like this, it means that this is attached on the two ends, but there is no zonule at all on the flat area. So the management is different, and the likelihood of vitreous prolapse is much higher in this one compared to that one. Intraoperative challenges or preoperative challenges, visual acuity is not correlating to refraction. That may be one indicator. There can be lens-induced glaucoma if the lens is in the anterior chamber, possibility of decompensation. Sometimes there in the mesopic conditions, the lens will come forward, and when the patient lies back, it goes back. So we need to be careful about that. The lens itself can be mature or high pitch mature, and flattening the anterior capsule is not possible in these kind of compromised zonules. Lens-induced uveitis may be present, imminently dislocating into the posterior segment. Once we finish the block, after giving the digital massage, we found that the lens was on the macula, so it became a retina case. And all these cases, retinal detachment is very possible. Intraoperative considerations: cataract surgery increases the risk of subluxation, vitreous loss, posterior dislocation, even IOL decentration at a later stage. Choice of anesthesia, whether you would give a peribulbar block or whether you would give a subtenance, is important. Wound, how you will position it so that you are not making your main tunnel in the area of dialysis and vitreous prolapse. The rexus must be centered on the bag. Hydro, you have to do a good hydrodissection and get a good rotation of the lens. Nucleus disassembly techniques will be covered later. Fluidics may need to be low fluidics to prevent fluid from going posteriorly. Choice of IOL and lens stabilization. So based on surgical experience, you will look at whether it is static or progressive. Static CTR may work, but progressive, you have to do some form of fixation with a suture. If it is normal cataract, you can go for a slow motion phaco. Very brunescent, maybe a SSCS or ECC is what will happen. Depending on the extent of zonular weakness, you can decide how to fix with what. No CTR, CTR, CTR with fixation, or a SFIOL or a ACIOL. Various devices, we should have this inside the OT, capsular hooks or the ASIA anchor. Intraoperatively, capsular tension ring, prevent the collapse of the equator, maintain the contour of the equator, tamponade the vitreous from coming forward, but it does not prevent the anteroposterior movement of the lens itself from where it is hinged. And the Bonnie-Henderson modification, where you have this kind of a corrugated structure, makes I&A easier in these eyes. When to insert the CTR? After hydro, full advantage of CTR is there. Safer removal of nucleus, but insertion may be difficult. And if at that time the zonulopathy progresses and you lose the lens bag complex into the vitreous, then it is much more of a challenge. After nucleus emulsification, better visualization, easier to insert, but then you may end up with a cortex entrapped in that. After IA, it's maybe for long-term IOL centration, but you have to be certain that you haven't lost the back by then. Various sizes are available. Larger size is preferable. The fixation, Sioni ring, and the Malogan modification difference is that one, you suture at the middle, whereas the Malogan modification is suturing at the end. The capsular tension segments are much less bulky, easier to implant, and this is what I prefer currently. When it comes to counseling and consent requirements, we have to say what is the procedure, why it is needed, who will be doing it, make sure that it is always a senior surgeon that does it. Any other alternatives in these individuals, the side effects of the procedure, complications, and that is very high in this kind of a situation. Need for repeat surgery, especially make a note to say that you may end up aphakic at the end of the first surgery and may need IOL implantation as a secondary, need for periodic review and possibility of complications. Thank you very much.
Thank you. Thank you very much, Dr. Matthew. This is a very crucial stage in subluxation. Once you identify subluxation, that you need to tell the patient and inform the patient. So what I do is I just show this patient the picture of the eye. I have a live TV connection. So the normal eye will be shown on a monitor, and this will be shown to them as their lens, which is not in the normal position. So first of all, they have to be convinced with that. After taking up, if something happens or if you identify on the table, it's very, very difficult to convince patients, especially in private practice. That is the most important take home for subluxated cataracts in private practice especially. So we move on to Dr. Sudeep Das, who will tell us on how to do SICS in subluxated cataracts. You know, SICS, people say, okay, it is difficult, just do SICS. That is not possible. Just doing SICS in a very difficult situation, this is not at all possible for very novice SICS surgeons. Or people who don't know SICS say, only phaco, but in between, when there is subluxation, we'll just do SICS. It is not possible to do good SICS. So how to get the advantage of SICS? By practicing well in regular cases and the modifications required. Dr. Sudeep, nobody better than Sudeep to explain on this. Over to you, Sudeep, please.
Thank you, Meenu, for having me here. Wonderful. Always love coming to KSOS. So precautions to take in subluxated cataracts. If there is a very grossly dislocated subluxated, then don't even plan for anything. Plan for ICC, SFIL, iris claw, whatever you're comfortable. Use hooks to support the areas of zonular dehiscence. It doesn't have to be all 360 degrees in all cases. And AC, one thing one should remember in all these problem cases, including subluxation, the AC should never become flat or excessively deep. So I had a case where, I think I'd sent a video to Matthew, where I had hooks and I injected a lot of viscoelastics. The lens went against the hook and it broke because the lens moved back against the hooks. So rexes should be adequately sized for easy delivery of the nucleus out of the bag. Preferably use sandwich, an implant CTR. If there is, even after the IOL implantation, if you see a distortion of the bag, ovalization of the rexes, put in a CTR. An IOL can be placed in bag many of the cases, but choose a 3-piece IOL if implanting in the sulcus. So this was a traumatic subluxated cataract. So you can see there's a localized zonular loss in one side, and you can see folding of the rexis or the capsule also when I'm doing the rexis. So I always prefer going through. You can see how it's sort of, there is a sort of a fold there when I'm doing the rexis. So these are, I'm making these very scleral openings. This I learned from Dr. Chi Sun Fake from SNEC. So when I need, I will use these hooks, but I don't want to lift up the bag and the anterior capsule, so I want them to be more scleral, very close to the capsular bag. So as you see, these are not the same as what we use for pupillary dilatation. These are iris hooks, but they're gone in very, very posteriorly. So they don't actually lift it up. And don't tighten the hooks very much, because these are not long hooks. You don't want them to go up to the equator. So they're sort of just supporting the bag. And there's one, so there are 5 of them. One of them is going behind the SICS tunnel, superiorly. So this is what it looks like. And then extend the wound. So this is like a pentagon. The nucleus has come out. Be careful at this stage because you can still rupture the capsule, the margin. This is not a very hard cataract, but it is a formed cataract. So this was, like I said, it's not a very hard cataract. I could actually remove it with viscoelastic itself. But if it's much harder than this, then yes, use sandwich or whatever. No reason that you can't use Simcoe through one of the side ports, but I don't use a Simcoe ever in my life. I use a bimanual for everything. So here be careful how much viscoelastic you insert. If you put too much of it, then the bag is going to tear. And this was a sort of a traumatic subluxation, so I don't expect the zonulopathy to become any worse. So I'm putting this IOL in the bag itself. So, and actually later on I put a CTR also in this because of ovalization. I won't go to that. This is a really tiny pupil, so I really don't know what to expect in this. So I put in, and once I started doing the rhexis, realized that the zonules are also weak. So actually why I wanted to show this is you can shift the hooks from the iris to the rhexis margin and support the bag also in cases like this. And if you see, I trimmed the hook on that side because if I don't, it will keep touching the eyelid and the hook will keep coming out of the bag. So trim it so that it doesn't touch the lid. Then again, after that it was routine. Did a sandwich and put the IOL in the bag. And this is a case where it's, as you can see, it's sort of a hypermature. You can see it's very difficult making even the initial nick. It's a sort of a Morgagnian cataract. Zonules are weak. So here I wouldn't actually do a rhexis. So make a small hole. You can use two lance tip blades also to make the initial opening. And then you can, here I actually tore the lower part of the capsule, but sometimes I support the bag with the capsule with my left hand and use micro scissors with the other hand and cut it off. So whole thing is there. Here if you do a rhexis, then the process of dislocating the nucleus from the bag will be even more traumatic. So basically just remove it with viscoelastic. It's a tiny nucleus. And then pull it out with Vectis. There's no cortex, so I'll put the lens, 3-piece lens in the sulcus. And then remove the viscoelastic. So always have a bunch of 3-piece IOLs so that I can do this. So these I will not implant anything in the bag. This was a long-term traumatic subluxation again. So there's one area where you can see the zonular dialysis. The rest of the capsule is actually, the zonules are all right. So I thought there was a gap there, so I sort of injected viscoelastic there to prevent the vitreous from coming out. Then tried staining the rest of the capsule. But some of these calcified fibrosed capsules don't actually stain very well. But here you can see the folds in the capsule. So it's really thick, it's like a cardboard. And this is absolutely no way that I can cut this. So just make an opening wherever one can, and then use scissors for the rest. But as you can see, the rest of the zonules are pretty all right here. So basically, it's on the nasal side that the zonules are gone. So cut that capsule off, remove that bit of cardboard. and I'm trying to dislocate whatever I can. So you can see even the nucleus is shaped like a bean and sort of comes out. And then I'm wondering where to implant the IOL. So use a 3-piece IOL. I can't implant one haptic on this side. So I think I can probably try to separate this out and place it in the bag, but then the IOL doesn't really center. So this is in the, at least that part is in the bag. But I'm trying to see if I can manipulate that fibrous capsule and get it to open, which is impossible. So it's so thick, I'm not worried about it giving way, and there's no zonules on that side. So I'm just trying to see if there's some way I can, but then decided it wasn't going to work. So I just tried to cut out as much of the remaining capsule from that side as possible. And trying to sort of manipulate it into the sulcus. And that's probably just about the best that I can get, but we compare it with normal. So it's fairly centered, and as you can see, the center is sort of all right. Thank you.
Thank you, Dr. Sudeep. Actually, SICS, doing SICS, there are some modifications which you definitely highlighted, and thank you very much for showing all those hooks and the use of all the instruments. I think the next talk is also on that. But what I wanted to tell was, if you, just pointing out, you can have micro scissors and micro forceps also in hand. Doesn't mean that just because you have a large incision, you have to go through that incision with larger instruments like vanas. See, always you can go through a paracentesis and cut at a different angle. So you will be able to cut these kind of capsules and other things, or hold onto the capsule differently from a different angle. So a micro incision scissors and forceps will be useful also, and also the use of viscoat and sodium hyaluronate. That is also very crucial, because when you are entering into the chamber will remain much formed, and also it can, this dispersive viscoelastics can plug your area of zonular dialysis and prevent further egress of viscoelastic. So after this, we will move on to Dr. Chitra Ramamurthy. She will talk to us on capsule stabilizer rings, hooks and phaco techniques. She is a very prolific phaco surgeon, and we would like to hear the details from you, madam. Over to you.
Good afternoon, one and all of you, and my very special thanks to Dr. Meenu Mathan for remembering me for his course. My due in the next few minutes is to talk to you all about subluxation in different cases. So when the lens is displaced from its normal position but remains in the pupillary area, it's called subluxated lenses. And when it is completely displaced from the pupillary area, it could be anterior dislocation or a posterior dislocation. Again, it's very important to know what is the extent of zonular weakness before you start, and based on Klaukas, it's divided from mild, moderate, severe, and very advanced zonular weakness. But one point to remember is that what you actually see on the slit lamp may not correlate exactly with what is on the table, so on the surgical table. So you should be prepared for a greater zonular weakness than you saw. It is also important for us to know that what is the kind of zonular weakness. Is it a progressive disease, a progressive zonulopathy like a pseudo-exfoliation of Marfan's, which has to be tackled differently as against a traumatic or an iatrogenic zonular weakness. Again, if it is dislocated, it's lensectomy either on the limbal or the pars plana route, and these are those AC IOLs, iris clip and SF IOLs. But if it is just a subluxation and you're going to conserve the capsule bag, that is when you're going to use the CTR, the iris or the capsule retractors, or the CTS. The most important thing is how do you get your rhexis. It needs to be a centered rhexis. There's a lack of zonular traction. So it's very difficult to size the rhexis. So you need to aim for a little smaller rexus. You should inject cohesive viscoelastic to flatten the dome of the anterior capsule. You could actually have to initiate the rexus from the area where the zonules are intact towards the area of zonular weakness, and you could use counter traction with capsule retractors. Now, how do you stabilize the capsular bag? You could use iris hooks, capsule hooks, CTRs or Ahmed segments, and I'm going to be showing you videos as to how I used each of these in different moments. Now, this appeared to be a normal cataract. There was no phacodonosis. I've injected the dye, but the minute I start my rexus, that tactile feel is not there. I know that the bag is loose. So I decide that I'm going to make it a small rexus, and I gradually, with greater confidence, enlarge it to a fair size. But I know that I have to place capsule hooks, not iris hooks, to stabilize the capsular bag. It might be appearing like an overkill at this time. The nucleus is rotating well. I'm able to chop the nuclear fragments, and I'm actually chop it. Everything, the AC is stable, but then look at that small area superiorly. That small area of zonular weakness, I immediately place a capsular hook. But the fact that there is followability and ability to rotate says that there is no vitreous disturbance as yet. But then I realized that the bag is really weak, so it's the time to place the CTR. And I use my second hook through the side port to tuck the CTR in, because with the nuclear fragment, you might inadvertently place the CTR in the angle and not within the bag. You need to circularize and stabilize and give it the equatorial support. I keep the phaco probe in the pupillary area, get the pieces towards, bring down my phaco parameters when it comes to the last fragment, and then without removing the cortex, I place the IOL inside the bag like an IOL scaffold, because I want that IOL to stretch the capsular bag. And then, yes, it is a little more difficult with the IOL and the CTR to tease out the cortex, but it has to be done tangentially, but you can get away with it. Now, this was the second case where there's more than 4 clock hours of dialysis. Again, you need to get a nice round rexus. That's an absolute mandate. You need to do a good hydro, because you want your nucleus to be mobile, because phaco manipulations with a not so mobile nucleus would increase the stress on the zonules. Then I place capsular hooks in that area alone, do a stop and chop, finish with the removal of the nuclear fragment. And the plan of action here is to place a sutured Sionis ring. I pass it in a clockwise direction and position the eyelet in the area of maximum weakness. And then I remove the hooks, place the intraocular lens. This is a very old video, and here a triangular flap is created in the sclera, and then the railroading technique is done in the usual manner, so that I get both the sutures under the triangular flap, suture it, and thus ensure that the bag is attached to the scleral wall. Now, this was a case of an iris and a lens coloboma. So this, of course, it means that the zonules could be weak there. The zonules in the other part could actually be fairly strong. I've injected a cohesive viscoelastic in that area of weakness to push back the vitreous so that it doesn't come forward. I initiate my rexus such that the rexus is less towards the area of the zonular weakness and more away, but ensure it is to be a nice round rexus. Now, that is an absolute critical factor which you need to address when you're doing phacoemulsification in a subluxated cataract. So after completing my rexus, I definitely do a hydro, but again, the only challenge here, there could be a fluid misdirection, wherein during a hydro or during a phacoemulsification, fluid can go in behind the lens and can make it a very shallow anterior chamber and a lot of pressure in the eye. However, that did not happen, so you need to keep injecting viscoelastic in that area to push the vitreous away. Everything seems to be going well, so I go ahead and even try to remove the cortex. But a point comes wherein there is a doubt. I realize that it's time I place my CTR at this point of time. Many a surgeon would want to place a CTR right in the beginning. That would actually have a preventive role in causing fluid misdirection. However, that was done and the lens was placed. This is another kind of a coloboma. Maybe an overkill here, but I have made a Hoffman's pocket at this point of time. And now I'm going to make a nice round rexus away from the area of probable zonular weakness in that area of coloboma. Again, herein you could place your CTR right now but I still go ahead and do a hydro. It's a very soft nucleus, so with IA, I'm able to aspirate all the lens matter. And now I place my CTR. Now, when you place your CTR, you should ensure that the eyelids do not overlie the area of zonular weakness, but rotate it such that the long arm comes to lie in the area. Now, probably I could have placed my lens there because I know the other areas of the zonulus are fine, but then you need to remember that this area of weakness could cause an asymmetric back contracture because of which a CTS was placed. This was a case of a very significant zonular weakness. So again, a Hoffman's pocket is being created, as you can see here. The extent of zonular weakness is very significant. I'm injecting viscoelastic to push back any probable vitreous, flatten the dome of the anterior lens surface, and initiating a rhexis in this extent of subluxation is truly a difficult fact. You have to keep pulling the rhexis towards the center while initiating rhexis. Capsule hooks are placed. Again, it's a very soft cataract, so IA is used to aspirate all the lens matter. You need to then, after you have removed all the lens matter, you need to inject viscoelastic. Never over distend the bag when you are dealing with a subluxated cataract. A second hook is being placed here, and now I'm going to place the CTR into the capsular bag, which will circularize it, but that does not suffice because the extent of zonular weakness is too much. You have to place a CTS, a single CTS or a double CTS, and now I decide to remove one of the capsule hook. The CTR is there in place, and now I'm going to pass a suture through the eyelet of the CTS, inject viscoelastic to push back the posterior capsule and position the CTS in that area of maximal zonular dialysis, and again do the railroading technique, which is a skill which needs to be acquired, and then complete the case. Now, when there is a very significant dialysis, a severe pseudo-exfoliation, you need to be able to assess that doing phacoemulsification will be very hazardous. So the plan of action from the very beginning was to do SICS. The plan is also to use the iris clip lens. So a 3 o'clock and a 9 o'clock incisions are made, through which I'm going to tuck in the haptic in the iris. So I'm just trying to confirm what is the extent of dialysis and use my lens scoop and get the entire nucleus along with the capsular bag out. The pupil is quite small. I need not inject a pilocarpine in this case, but you need to do a shallow anterior vitrectomy to ensure that if the vitreous is cut. And I believe if the vitreous is well cut, you need not even do a PI in these cases. And I'm not going to actually go in and show the details of how the iris clip is placed. It's done, and it should be something which you all know. An extreme situation, a very pseudo-exfoliation, progressive in nature, and if you've just placed a CTR in your cataract surgery, you could have the whole thing subluxating into the vitreous, which is when you need to do a glued IOL or a SF IOL. So essentially, the whole route of how you're going to manage subluxation depends on the extent of subluxation which you visualize, a CTR, using capsular hooks or iris hooks, or going on to a CTS, or deciding to do a glued IOL or iris clip IOL. Thank you very much.
Thank you very much, madam. This was a master class in itself. So this is a very extensive description on how to do a perfect phaco in all these kind of different situations. I don't have anything to add on to this. Any questions to her? I think we'll take it at the end. Thank you very much, madam. So we move on to, after seeing all this, we move on to anterior vitrectomy and IOL placement options in these kind of cataracts. We have seen quite a few, so I'll skip through some of my talk. So anterior vitrectomy. So in subluxated cataracts, some cataracts will have vitreous in the AC to begin with. Some we will get vitreous inside when you start doing phaco or when you are through the phaco. So whenever there is vitreous in the AC, complete a vitrectomy and then proceed with phaco. That is the golden rule. So here in the beginning itself there is vitrectomy. So irrigation and vitrectomy. So through the main incision there will be leak. So it's better to do a vitrectomy through perfect fit side ports. And adequate vitrectomy to clear the anterior chamber alone. Don't keep pulling vitreous from wherever there is a dialysis. Go into the dialysis area and keep on doing. You will lose vitreous support. It is very, very important to have vitreous support for these kind of subluxated lenses to be held there during surgery. Once it is done, as madam was showing, the viscoelastic which is injected is very, very crucial. Viscoelastic is not just HPMC. So see, in this case, there is no vitreous here, but this is a large area of dialysis. From anywhere through that area you can get vitreous coming out because of the irrigation, aspiration and all which happens. So I would use Viscoat or Orocoat Plus. No financial interest in any of this, but these are the dispersive ones which will remain in position. Cohesive ones will get aspirated off immediately when you go near it with the aspiration port. So your phaco should be slow motion with low flow rate and aspiration, but still if you have Viscoat lying there plugging that area, you can see that I am putting in Viscoat from the opposite side and plugging that whole area, and after that I am comfortable doing a Rexis with the HPMC inside because the feel of the capsule is better, or I am used to it if you put in HPMC. So as madam was telling, having a Paka Rexis is the prerequisite to continue with the phaco. Otherwise, forget about phaco. In a subluxated cataract, forget about phaco if you don't get a Rexis. So here, as it was shown before, it's a diffusely weak zonules. Traumatic, so not progressive. So here again, the capsule is held with the iris hook itself. You can. Only thing is, when the chamber fluctuation happens, if it is not a capsule hook, it may just come off. When it deepens, it will just come off. So that is one disadvantage of iris hooks. So the advantage is that madam was showing in the last video MST hooks. MST hooks are much more friendly than the initial ones which were shown, Indian made ones. They are costlier, but we can reuse them. They are broader, they go long towards the equator, and the idea is to support the equator, not to just hang the Rexis margin. So that we have to be very clear about it. The tip has to go hit the equator, and the equator is being pushed with the capsule hook. So here this is subluxated zonules in pseudo exfoliation. So here you can notice that I have held the pupil with 4 hooks, then I have held the Rexis margin with 4 other hooks and completed the phaco. So after this we need to know, see, as we were all talking and we are seeing nowadays that 15 years after your pseudo exfoliation phacos, many of them come with the decentered IOL. Almost every week I see one with decentered IOL bag complex. So they all decenter mostly after surgery, especially after surgery. Without surgery, the lens remains there. It dangles, but it remains there. But after surgery, the Rexis contracts and the peripheral zonules are weak, and zonules keep giving way, and the phimosis and the contracture of the bag will accelerate this process. So here we will have to put in a capsule tension ring. So while putting in a capsule tension ring, I am having my hooks on so that the bag is stretched. So the second, the trailing part of the ring, you can use a Sinski, or I would use now a micro Rexis forceps. We can hold it till the end, till the Rexis margin, and leave it and guide it with your Sinski. That is what I do right now. Now I remove all my 4 hooks from the Rexis margin so that I can put in the IOL. But these iris hooks remain on the pupil because visualization is very, very important. Don't do anything under the small pupil area. And the 3-piece lens, I now prefer the Oro View 3-piece lens, which is 13.5 millimeters, half a millimeter bigger than any other 3-piece lens available, or a Technis 3-piece is also fine. But to remain in the sulcus, the larger the better. But once in the sulcus, for long term, it is better to capture the optic in the Rexis margin. So here I tap one half of the optic underneath the Rexis margin, and now we can see that there is a lot of visco inside. So while placing the IOL, I put only sodium hyaluronate, which can be easily and completely aspirated off. So that has been irrigated, and even you can aspirate also. Later on you will get a lot of capsular bag distension if you leave visco inside the bag. And now the other part is also nudged into the bag, and now this remains on top of the bag, and this phimosis is also prevented or reduced a little bit because of the stretch at 2 corners. So that prevents or reduces the rate of phimosis, and both these together will reduce the later decentration and dislocation. So now during the surgery we could see movement there, and there was vitreous. So here again I stress, please do vitrectomy but do only enough vitrectomy to clear the vitreous off from the anterior chamber and plug that area with dispersive viscoelastic. Because the more you do, the more the lens will flutter and move backwards when you get in your phaco probe. So once that is done, I don't want to show the phaco part of it because it was shown. And I finished the IA and then just try to identify, the pupil becomes small, and then identify where is your rexus. So this is the rexus is good and it was all going fine. I thought the bag is also stretched with viscoelastic very much. But when I was just trying to aspirate, see the bag separating off more than 180 degrees of bag subluxation. So here again I felt, because it was the intraoperative, I could get away with the CTR, and regular CTR goes inside the bag. Nothing new about it. The lens also goes into the capsular bag, and it is very well centered and nice looking at the end of this one. So after many months, the same patient comes back to you. Don't go anywhere. We'll come back to you only. And then move your head and show. See, dangling, something is moving. Whenever I'm looking top, fan is rotating, fan is moving and all. So now what to do? We will have to fix it. You can tell that you did something. Did you not rub your eye hard when something went into the eye? Oh yes, 1 or 2 times. That is the reason, that's all. You can find a reason very easily. And then you put in sodium hyaluronate in front, and we can see the lens is just floating. But we have the CTR inside, that's a great advantage. So once you have the CTR inside, we can fixate this along with the bag. So that is what I want to show. I don't want to mix vitreous with this. So put a sodium hyaluronate under the bag also. So this flap need not be that big, but at least 3 millimeter long flap is needed. And marking 180 degrees, very, very crucial. Otherwise you will get a tilt or a decentration after you fixate the IOL. So marking 2 millimeters behind the anterior limbus and going in with a 27 gauge needle. So your 27 gauge needle and your 90 Prolene needle should go in. After entering both needles inside, you will realize that the needle is not going into the hollow of the hollow needle. So make sure that your Prolene needle will go into that first outside, then do this. And the needle is placed behind the complex, and the Prolene needle pierces the bag and comes out, and the same thing is repeated on the other side. This time the hollow needle comes above the complex, and the needle goes again back through a paracentesis, and this will form a loop and you can pull it on. And now just give a little traction and center it, and you can decenter it a little bit so that you can see this part more clearly. And for better visualization, these 2 hooks are placed on either side of the flap. That is very crucial. And after doing this, don't tie now. Make 3 throws and make a knot and make the other side and see how centered it is. And don't lock. After centering it, then lock. Because once you tighten and center, you will see that it is decentered to one side, and the next side if you pull, it will not center itself. So then you can have a centered complex. So this one was already shown. Once you place a CTR and the lens inside, if you feel that it is not centered, you will have to fix this, because it is not going to be centered, and later on it can get further decentered. The same thing which we saw, the Ahmed segment, which is very useful just to get into the area where it is maximum subluxated, and the same kind of railroading which we saw before. The two loops go in, and then you don't have to pull too much. Make sure that the 2 Purkinje images on the cornea and on the lens will match, and when you place the eye straight looking ahead. So this is again the Zioni ring, not very hard to get, but then it's difficult to use to put it inside through the main incision, and I would nowadays not use this. I use a CTR and then use a CTS along with it rather than using this, because it is a little cumbersome and difficult technically. Once there something goes wrong, you lose the whole bag and the whole procedure is lost. So I don't want to promote this by showing this again. And if you are not okay with all these and the subluxation is too much, the other option is to place, to take out the whole bag and do a vitrectomy and place anterior chamber lens, iris clip lens, or a glued IOL or a scleral fixated lens. Iris clip lens has been shown by madam. I personally don't do it, and that's why I am not showing it. I have nothing against iris claw lenses. Please continue to do if you are okay doing with this. And it is not yet time to right away AC IOLs. This is what Dr. David Chang himself says. He said that 10 years before. He said that 3-4 months before in the Andhra Pradesh annual meeting. when we had his virtual conference. So I personally asked him at that meeting itself, sir, don't you have that reference with you? He said, yes, there is a meta-analysis published in ophthalmology telling that if you do everything properly, ACIOLs have the same outcome on long term as the scleral fixated. Iris fixated is not studied because it has recently come, and so that's not there. So it is very important to do a complete anterior vitrectomy. Even if you do not have a vitreous loss, I will do anterior vitrectomy for ACIOL. That is one. Second thing, we should have a pupil which will contract and at least reach 5 millimeters. And the third thing is sizing. So measure your white to white properly, see which is the maximum and which is minimum, and you should have at least 0.5 to 1 millimeter larger overall sized ACIOL with you, and then doing a proper vitrectomy, proper iridectomy, one or even two. If you are not sure about one, make two. So you have your lesser cut rate and use your vitrectomy probe itself, and this is not the right thing to do. Extending on the cornea 5 millimeters, not the right thing to do. So please cut backwards into the sclera and then make scleral pockets and extend, or go to a different location, abandon this corneal incision. And the lens always comes with the angulation facing down in the package. It is packaged like a PCIOL. PCIOL is also angulated backwards like so. The optic of the anterior chamber lens should be facing away from the pupil. You don't want to have pupillary block even though you have a PI. So tilt it, flip it once you take it from the, once I flipped it and I forgot whether I flipped or not. After taking it out, I just took it out. I usually take it out just like this, like flipping it automatically. Later on, once I placed, it looked like it was not flipped. And it's very difficult to identify in the anterior chamber once it is placed. I asked my PG, did I flip or not? What is flip, sir? He doesn't even know what is flipping. And so this is what I am telling. So when and then I asked my assistant nurse, did I do that flip? She said, sir, ഞാനത് തുറന്നപ്പോഴേ അതിങ്ങനെ വളഞ്ഞിരിക്കുകയായിരുന്നു സാർ, പിന്നെ സാർ അത് തിരിച്ചോ ഇല്ലയോ എന്ന് എനിക്ക് അറിഞ്ഞൂടാ സാർ. No, what to do? So I finally explanted that lens, took it out and saw the alignment. Okay, anyway, actually it was flipped. But then anyway, I took it out and placed once more. Because I have seen a patient go total optic atrophy, glaucomatous optic atrophy, just because there was no PI and a reverse placed ACIOL. Patient did not know. Some rural patient came with GOA, and this is the only reason. So always the placement part and the PI is very, very crucial. And now we need to place it. If you think that you have 12 millimeters, and when you place horizontally, it is feeling not that very tight. When you touch it, leave it, it is not springing back. It is just moving a little bit when you tap it. So then place it vertically. So vertically, if you go, you have a 0.5 millimeter advantage. So rotate it and place it. So when you are rotating, it can be rotated either directions. But make sure that the open end does not go into the PI. So sometimes it goes into the PI. So lift it and place it rather than rotating it. So nobody else to talk here. So we'll go on 5 more minutes. And then again, suturing is very important. If you feel that your tunnel is not great, please do suture, because that is very, very important. And ECC sections, if it is ECC, people used to say not to place the haptic just under your ECC wound. But in a tunnel, I don't think it's a big deal. It's a problem placing the haptics underneath your tunnel if you have a good anterior corneal entry also. And if it is loose, if it is smaller than your white to white, that is more problematic. There is more pseudophagodonosis, and the pseudophagodonosis itself can cause aberrant currents inside the anterior chamber. Need not directly touch. It can cause the direction of aqueous flow inside. It's all turbulent always, and it causes long-term endothelial damage. Otherwise, endothelium, nothing happens to endothelium. So once moving on to glued IOL, it is very important to know few steps. Okay. So marking 180 degree, very, very important. So this is a good instrument to mark your size of the flap. So if you are placing this glued IOL, I nowadays do only 2 millimeter by 2 millimeter. So 180 degree opposite is very, very crucial. So 2 millimeter and backwards 3 millimeters. So AC maintainer, either you can use your AC maintainer, or I nowadays use the trocar cannula, which is used by the retina people because it stays in more tightly. And then 2 millimeters behind, and see what size of forceps you have. And the opening should be enough to get your forceps inside, 23 gauge or 25 gauge or whatever. and then one paracentesis, and your incision has to be 90-degree opposite to the flaps which you have made, very crucial. And then hold the tip, don't leave, and then keep injecting. While injecting, do not lose view of the tip, otherwise we will sometimes loosen it off. Keep it tight and let the whole optic go inside, and then flip your trailing haptic properly and then bring out. Once it is brought out, I didn't show you that, but then there's a silicone stopper which has been introduced in. The iris retractor hooks stopper itself can be used. That will retain this one, that it will not go back. And this is the handshake. To get it inside, hold not at the tip, but hold it away from the tip, and once you get the forceps on the other side, again hold at the tip. Otherwise the tip will get deformed and you won't be able to tuck it inside. And once it is taken out, then you loosen this silicone tip, and then I first, after bringing it itself, I get it into the scleral pocket. I'll show that pocket next after this. And it is tucked on both sides. Tuck it, retuck, center it properly, and close. The incision can be closed by suture if you think that it is leaking, otherwise it need not be. And all these incisions are hydrated, make them leak proof. And then use the glue. If you have glue, use glue. But glue has nothing to do with holding the IOL in position. It's the pocket which keeps it in position. If you don't have glue, no harm. You just suture the flaps with nylon suture, and then I put air inside so that there is no leak through the ports, and it has to be dry while applying the glue. And once it is done, it can be used for the conjunctiva also. But nowadays I suture the conjunctiva also because many cases it tends to retract. So I don't want the flap to expose and all this. So there is another, this is the Chariot's pocket, which is very crucial. It has to be right next to your sclerotomy opening, and use a 26 gauge needle or even a 1 millimeter slit knife is also fine. It need not be so tight fitting for the haptic. It can be loose inside. It doesn't get decentered. And this is the new lens which has come up, made in India, Appasamy. It is the CMT Flex. Gives you some advantage in haptic positioning because it's a T. You can see it is a T at the end, and this loads like a regular IOL in a butterfly cartridge, and the T should be placed straight, and it should go into the nozzle here and folded like the regular IOL. And it's a modification by Dr. Nivian from Chennai. And see the tip coming up, and then inject. Here the difference is that the incision has to be slightly away from the center because holding it will be easier, and the flap size is larger, 3 millimeter by 4 millimeters, so that the tip gets nicely buried there. And once the tip has to be held, the center, not the edges, it has to be held at the T tip. Once it is held strong, inject completely, and then retract this. I will show you in the other video. And the next side also, hold at the junction and exteriorize it. And this was not there in that video, and that's why. So once it is held and pulled, you can notice that it gently comes out, and once it is out, it just sits there. See that? It just sits there. You can leave it there. No more tucking, nothing. And the other side also, hold it and bring it out, leave it, and that's it. It remains flat. It closes the sclerotomy opening. That's very, very important. It doesn't leak at all. And nowadays I make a scleral flap thicker than normal because it's a slightly thicker part of the T, and it should not erode out through. So it doesn't erode if your section is nicely closed. Either you can use, it doesn't leak. You don't have to close it for the leak part of it, but then use glue or suture and close it. This is also less time consuming. In my part, the tucking of the haptic is a little cumbersome for me. This is giving me much better tucking of the haptics, and thank you very much for listening. And we have 4 or 5 minutes more where you can please ask doubts. All the faculty are still here. Yeah, we have questions. Please use the mic, please.
A quick point that I'd like to make.
Oh, I thought she was going to ask a question. She was going out. Okay, Matthew, please carry.
When you have a subluxated lens, you place the CTR inside, you have got capsule hooks on the margin. You saw what Sudeep did. He trimmed the length of the hook. So we have a situation where surgery was going well, everything was completed well. IOL implantation, so as we are introducing the cartridge in, the globe rotated, at which point of time the hook which was engaged to the lid margin and the drape margin sliced the edge of the rexus. In a normal situation with intact zonules, there is no problem. The tear will go up to the zonule. But here there is no zonule. Plus, the rest of the capsule is stretched because of the CTR. So, it comes as a small V, becomes a larger V, then goes posterior, and then finally, like opening a curtain, the whole thing opens out. So, you have to pull out the bag, you have to pull out the CTR, and it is like snatching defeat from the jaws of victory, because you are at the point of placing the lens, completing everything, and then everything is lost at that stage. So be very careful, and this is something that I learned new today. Having worked with this fellow for close to 10 years.
CTR, if you are in doubt, always pass a 10-0 nylon thread through the eyelet, and at the end you can cut it off if you are finding that it is in the right position and it's all good. But otherwise, if you want to explant it, otherwise it's very, very difficult. It goes into the sulcus or something.
Other thing is subluxated cataracts, you see them on a slit lamp and you don't know how far it will be. Like Matthew said, it may not be there when you go for surgery. So most of us have these patient chairs. So we make the patient lie down in the OPD and see with an indirect as to how far down it is. And you can actually figure out whether you can do it or your vitreoretinal colleague should be doing it.
Yeah, last week also I did one to a patient like this, and I asked my PG, why did I do that? She said, I asked the patient lie down, and then I went and saw and came. She thought for some time and then said, the patient in കുറേ നേരം ഇങ്ങനെ നേരെ കിടക്കാൻ പറ്റുമോ എന്ന് അറിയാൻ വേണ്ടി നോക്കിയതല്ലേ sir. So the point is that we need to know whether the lens will be there accessible to you during surgery on the table. That is very crucial.
The other point is, if it is a small area of zonular weakness and you think there is vitreous there, it's important to just gently stain that with tricord, assess whether there is actual vitreous, and do a very limited vitrectomy. Ideally, you should not even do an anterior vitrectomy, but you are doing anterior vitrectomy, you should be careful that the infusion cannula is not directed towards the vitreous, because more vitreous will start coming and the area of zonular dialysis will increase. And if you are good at doing a pars plana vitrectomy, it's actually sensible to go through the pars plana route, because that way the vitreous will not come forward.
There was a video shown when they did a pars plana, they cut the posterior capsule also in a subluxated capsule. So when you are visualizing, please visualize the cut when you are going pars plana. Yeah.
So when we encounter, usually on the morning of the surgery only we see pseudo exfoliation cases being posted. They must have been counseled for premium foldable IOLs. So going in the ideal way, there is no clinical subluxation. Even during surgery, not so much of zonular weakness. Should we keep quiet, put the foldable IOL in the bag and come out, or ideally should we re-counsel the patient for a foldable 3-piece IOL and do an optic capture? Because as you rightly said, even later on, the PXF changes can worsen in long term.
So every lens now will have, I have a 3-piece option for every lens. Every lens. So patient is not told the name of the lens. It will be an Indian version of a foldable, hydrophobic, which will have AuroView 3-piece also as standby. We will place it accordingly on the table. The same charges, same lens. And the 3-piece, if you're talking about premium torics and multifocals, then it's a different issue. Don't do. If you have a doubt on the table itself, you have to counsel or take the patient out. Clarion, that's what. If you don't have a replacement for a 3-piece lens, then such cases, please do not implant if you feel that it's going to decenter badly later. Sometimes you'll be forced to do that, patient will feel bad, then he'll say, you didn't tell me before, and all those things. It's a very awkward situation. But then 3-piece lenses, till 3-piece thickness, we can always exchange it with the other single-piece lenses. But beyond that, it is better always tell the patient and the bystander before starting and then only do. I would say that, because private practice is very difficult to talk to patients, not like in institutes where you can tell later that something or whatever. Okay, so we have run out of time. Thank you very much for everyone coming. Sandhya has one question.
Yeah, one last doubt, sir. For the last lens you show, after making the scleral flap, what should be the size of the sclerotomy for the teeth to seal the wound, sir?
Tell me again.
So last case you showed, no, sir? For that, after making the scleral flap, what should be the size of the sclerotomy for the teeth to seal that wound?
It's a 23 gauge, it's fine.
It's fine, sir.
23
will come
gauge
out.
it comes.
Ah.
But then if you are beginning, no, don't try strain. We have people, Matthew had once torn the T off. Not Matthew tearing the T off. T can sometimes tear off if you struggle through a small opening. So I would say 23 and a slight extension while coming out. So, or make a 21. Even if you make a 21 or a 20 also doesn't matter. It closes. It just like that closes. So it will be easy to take it through a 20 or a 21 will be better.
Okay, sir. Thank you, sir.
Come, we'll have a